This is a brief summary of main motor pathways and associated diseases. This project was done by Thomas Nelson, Lindsay Smart-Smith, and Kate Smith, all PA students at A.T. Still University. In order to control our muscles, the brain sends signals or commands through two pathways, the pyramidal system and the extrapyramidal system. We will be focusing our discussion on the pyramidal system, also known as the corticospinal pathway. This pathway is primarily concerned with the voluntary skilled movements of the muscles of the distal limbs. Motor activity occurs in the precentral gyrus, just anterior to the central sulcus. The primary motor cortex is the executive motor control mechanism and is responsible for creating the neural impulses controlling the execution of movement. Most of the axons in the corticospinal tract originate in the cortex, specifically in the pyramidal cells of layer 5. Many of these cells are large neurons called Bett cells that originate in this layer. There are, however, some other areas that help aid in motor sequencing with fibers that originate outside the primary motor cortex. The non-primary motor cortex contributes to motor control and modulates the activity of the primary motor cortex. It consists of the supplementary motor area that receives input from the basal ganglia and modulates the activity of the primary motor cortex. It also consists of the premotor cortex, which primarily initiates movement sequences. The pyramidal system consists of neuronal cell bodies and their axons, which begin in the cerebral cortex and pass through the brainstem, forming the pyramidal tract to the spinal cord. These groups of fibers carry messages for voluntary motor movement to the lower motor neurons in the brainstem and spinal cord. The upper motor neuron axon extends all the way from the brain down to the spinal cord, and the lower motor neuron axon extends from the spinal cord to the skeletal muscles of the arms or legs. Here is a summary of the pathway of the corticospinal tract. The pyramidal tract fibers begin their descent from the cortex and then descend down the posterior limb and enter the internal capsule. The fibers then continue down and travel through the cerebral peduncle, the pons, and medulla, forming a small pyramid on the anterior surface of the upper medulla. In the middle of the upper and lower medulla, the fibers cross to the opposite side, an event called decussation of the pyramids. A few of these fibers, however, will continue to descend ipsilaterally. The right tract will control the left side of the body, while the left tract controls the right. Unilateral pyramidal tract lesions above the point of decussation in the pyramids will cause paralysis of the muscles served by the spinal nerves on the opposite side of the body. After they cross, the fibers now reside in the white matter of the spinal cord, in the lateral corticospinal tract. Most of the fibers cross, but of the fibers that do not cross, they will continue ipsilaterally down the anterior corticospinal tract. These fibers will then cross the midline once they reach their target motor neurons. As a safety method, most all of the cranial nerves receive bilateral innervation from their corresponding corticobulbar tract fibers. Each pair of cranial nerves gets innervation from the right and left motor strips in both hemispheres. So if there is a unilateral lesion on a pyramidal tract, then the cranial nerve will still receive some motor input and full paralysis will not occur. The two cranial nerves that receive contralateral innervation from the pyramidal tract and are the exception are the portion of cranial nerve 12 that provides innervation for tongue protrusion and part of cranial nerve 7 that innervates the muscles of the lower face. Here is a summary of main motor pathways. Take time to pause the presentation and review these pathways. There are other tracts that control motor commands besides the main motor pathway. These tracts lie outside the pyramids of the medulla and are consequently called extrapyramidal system. Components of the extrapyramidal tract include the basal ganglia, the red nucleus, the substantia nigra, the reticular formation, and the cerebellum. All of these structures send information to the lower motor neurons. Two principal pathways are the reticulospinal and the rubrospinal tracts. The reticular formation is a group of interconnected neurons found in the brainstem that contain zones that facilitate movements and zones that are inhibitory. The reticulospinal tracts take inputs that arise from the reticular formation and connect it to spinal interneurons. The rubrospinal tract arises from the midbrain's red nucleus and terminates in the spinal cord to regulate motor output. Amyotrophic lateral sclerosis, also known as Lou Gehrig's disease, is a progressive neurodegenerative disease of the nerve cells of the brain and spinal cord controlling voluntary muscle movement. Patients with this disease may eventually become totally paralyzed, resulting in death. The primary motor neurons are affected within the corticospinal and/or corticobulbar pathways, affecting voluntary movement and muscle strength. This involves both the upper motor neurons and lower motor neurons. Signs and symptoms of someone who has Lou Gehrig's disease are increasing muscle weakness, difficulty with speech, swallowing, or breathing, and as these muscles are used less and less, atrophy ensues. Hyperreflexia and hyperactive gag reflex may be seen on the exam. Another disease is poliomyelitis, also known as polio. Polio is a viral disease that can affect nerves, leading to partial or full paralysis, which is also paralytic poliomyelitis. This is uncommon in the US due to vaccinations. Polio infections are separated into three different groups: subclinical infection, non-paralytic poliomyelitis, and paralytic poliomyelitis. Take time to review their signs and symptoms. Guillain-Barré syndrome is an autoimmune disorder, which means the body's immune system attacks itself. Exactly what triggers Guillain-Barré syndrome is unknown. This syndrome often occurs a few days or weeks after the patient has had symptoms of a respiratory or gastrointestinal viral infection. Occasionally, surgery or vaccinations will trigger this syndrome. Early symptoms include weakness or tingling sensations in the legs and may spread to the upper body. These symptoms can progress to almost complete paralysis. The paralysis may take weeks to years to improve, and some will have residual weakness or paralysis. And lastly, pernicious anemia. Pernicious anemia is a decrease in red blood cells that occur when the body cannot properly absorb vitamin B12 from the gastrointestinal tract. Vitamin B12 is necessary for the proper development of red blood cells, as well as myelin synthesis. Therefore, long-term vitamin B12 deficiency can lead to nerve damage that includes symptoms outside of your normal anemic presentation. Nerve damage symptoms include numbness, tingling of hands and feet, confusion or change in mental status, depression, and loss of balance. Pernicious anemia is easily treatable with vitamin B12 replacement. However, if not caught early, permanent nerve damage may occur.